First, I want to thank Dr. Wiam and the organizing committee for allowing me to this stage. And I want to thank the people who stayed here till after 5. I'm sure they are exhausted. I know I am, though I escaped half maybe the lecture. So, okay, let's start. Adrenal insufficiency. We'll talk about diagnosis and management, and I have no disclosures. This is my outline. We'll have an introduction, then we'll talk about epidemiology and some clinical presentation, and then how we diagnose adrenal insufficiency and the management, and then maybe a couple of slides about adrenal crisis and summary. As we know, adrenal insufficiency first described by Thomas Edison in 1855, and synthetic steroids were not out till 1950. And so only we have the cortisone or prednisone for only the last 75 years. And we know it is a life-threatening condition. If it's not treated, it's deadly. And we know this could be primary adrenal insufficiency when the defect is the adrenal gland, or secondary adrenal, or tertiary when the defect is the pituitary gland or the hypothalamus. This is just a quick cartoon about the adrenal gland. We know the adrenal gland consists of two parts. The middle one, the inside, is the medulla. We're not talking about that. We are talking about the outside, the cortex, and it consists of three parts, GFR, if you remember it, glomerulus, which produce mineralocorticoids, and is under the control of RAS. And then we have the fasciculata, produce glucocorticoids, and the inner part produce androgens, and this is under the control of ACTH. And why this is important? Because the way how the patient will present to you. If the damage in the whole gland, the three layers will be affected, and then the aldosterone, steroids, and androgen will be affected. If only ACTH is the issue, like secondary and tertiary, then we have glucocorticoids and androgen will be affected, but not the mineralocorticoids. Just quick physiology reminder. You know our body produces between 5 to 6 milligrams of cortisone per meter square, and it typically have a diurnal rhythm when it peaks early in the morning. That's why we measure it usually in the morning between 6 and 9 a.m. And we know most of it is protein pound, and this is very crucial because we need to make sure the patient have normal CBG before we decide if their level is low or high. Typical condition that lower CBG, severe liver disease, severe acute illness, and some mutations in the protein. And someone is pregnant or taking contraception, you will have high level. Actually, about maybe 2 months ago, I got a referral for a patient who has polycystic ovarian syndrome, and the doctor ordered for her cortisone, came back about 30, 35, which was high. So question here, she was taking birth control pills, and that's what's expected. You stop it, and then it lowered down to normal. The reason is important here, we measure in the blood is the total cortisol, not the free cortisol. And that's why make sure CBG is normal when you order the blood test for cortisol. Some definitions here: primary adrenal insufficiency or Addison disease is the defect in the adrenal gland itself. Secondary is the pituitary gland, in which we have low ACTH production, and then tertiary, in which affect the hypothalamus, in which we have low production of CRH. Just a quick HB axis, this is the normal. Hypothalamus produce CRH, stimulate the pituitary gland, stimulate the ACTH, affect the adrenal gland to produce cortisol, and then we have negative feedback. If someone have primary, then we have destruction in the gland here. We'll have elevation of ACTH, elevation of renin, low aldosterone, and low cortisone, and low androgens. In tertiary or secondary, we have low ACTH, so cortisone is low, but aldosterone is normal because it's not affected, it's only controlled by RAS system. Epidemiology, the most common cause of adrenal insufficiency is tertiary, secondary to steroid use. Primary adrenal is rare. It's about between 90 to 140 prevalence per million. And in some countries, like in New Zealand, it's as high as 240 per million, the prevalence. And the incidence is about 4 to 6% per million. And it can present usually at any age, younger age, usually patient with genetic disease. And if it is autoimmune, between the age 30 and 50. And then the secondary is more common than the primary. It happens in the 5th and 2nd decade of life. And usually it's more common in females than males. And this is just a quick study to show you that how important is tertiary hypoadrenalism or adrenal insufficiency. A study was done, published a few years back in rheumatoid arthritis patient who took prednisone as low as 5 milligrams. What they found, almost half of them have adrenal insufficiency. Another study in patients who are taking currently different doses orally, or even inhaled steroids. Almost 60% of patients who take oral steroids have adrenal insufficiency. Almost 20% of patients have adrenal insufficiency who are taking inhaled steroids. So secondary dose is common in patients who are taking steroid. And this is very important when you see patients in your clinic and you or admission for surgery. The question comes, do you want to give them stress doses or no? Now, who's mostly affected? Females are more common to have than males. Usually it have two peaks. The peak when primary adrenal between the age of 30 and 50. For secondary, the peak is between 50 and 60 years of age. And remember, primary is the most common, is autoimmune. And most of the time we have another autoimmune disease with it, specifically thyroid, about 40%, and diabetes type 1, about 12%. So, when to suspect? Remember, it's a disease of master of non-specificity and disguise. These patients who don't have specific symptoms for adrenal insufficiency, the symptoms are non-specific. Patients come to you, probably for many years, being diagnosed with having viral infection, anorexia, depression, chronic fatigue syndrome, feeling tired all the time. Every now and then they're feeling hypotensive. Sometimes you check the blood test, they are hyponatremic, occasional hyponatremia, so they have no specific symptoms. So you need to have high level of suspicion before when you look for adrenal insufficiency. And the onset can be very gradual because you need more than 90% of the adrenal gland to be damaged to have symptoms. Or if the patient have acute request or requirement for steroids like in stress, then they present with the crisis. And if the patient having secondary and mineralocorticoid is not affected, even the delay can be even longer because the patient will not have hypotension or hyperkalemia. And also depends on the physical stress. If the patient have mild physical stress, may they present with fatigueness and tiredness. But if the patient presents with strong physical stress, they can present with the crisis. The features can be divided to three parts. One, which related to both primary and secondary. Then it's more specific to primary adrenal insufficiency and more specific to secondary adrenal insufficiency. One can be in both. Weight loss, almost all patients will come with weight loss. Most patients will come with fatigue. It's common to have loss of appetite, nausea, vomiting, abdominal pain. Actually, my first patient came with abdominal pain as acute abdomen, and she was planning to go to the OR. And the reason they found it, because she had hyperkalemia and hypoglycemia. I was actually an intern when I failed, and that's why I decided to be an endocrinologist. I found really nice. And then coupled to have muscle pain and joint pains in women, reproductive age, amenorrhea or infertility. Sometimes can be present with hypoglycemia. Psychiatric disorder is common, up to 40%, and they can present with anything from psychosis to depression, anxiety, impairment in memory, coma, delirium, organic brain syndrome, mania. So these patients can present with any psychiatric disorder, and it is common and early in the disease. Something peculiar to men is auricular cartilage calcification. I never saw it, but it's mentioned. It usually happens in adrenal insufficiency for long standing. It can be primary or secondary. As you can see here, there's calcification of the auricles. And when you do examination, you cannot bend the auricle here. And even it does not go with treatment. So this is it happens in men and is permanent. Lucky us. Okay, specific for primary, because we know in primary, mineralocorticoid are affected. So these patients are more common to have dizziness, postural hypotension, salt craving. They love pickles. You see them, they love pickles all the time. Even sometimes come to the clinic with water with salt in it. Hyperpigmentation, because high ACTH will increase melatonin and hyperpigmentation. And it's common to have vitiligo because of autoimmune disease. For example, this patient came with darkening of her face, hyperpigmentation. Look at the creases here, dark. And then after a treatment, improvement. Another patient, he was normal here 6 months ago. And then when he was diagnosed, dark. And this is a few months after a treatment. Another case, hyperpigmentation, the mucous membranes. And you can see hyperpigmentation on the thigh here. And this is another patient in which have vitiligo and then hyperpigmentation. What about secondary? We don't see these symptoms typically in secondary. These patients they have other pituitary hormone issues. We don't see hyperpigmentation. We hardly see hyperkalemia, dehydration, hypotension, hyponatremia, or GI symptoms. The reason for that, because GI symptoms, for example, is because of electrolyte imbalance. That's why they present with abdominal pain and GI nausea and vomiting. Hypoglycemia, interestingly, is more common in patients who have isolated ACTH deficiency. These are the lab findings: hyponatremia, hyperkalemia, acidosis, eosinophilia, lymphocytosis, anemia, autoimmune with hypothyroid. Rarely you can see hypercalcemia and hypoglycemia. So whom to be tested? We divide the patient to 3 groups. The first group who are suspecting adrenal crisis. A patient comes to the ER with vascular collapse, no apparent reason, then we suspect adrenal insufficiency. Or patients who have the symptoms suggest chronic adrenal insufficiency like fatigue, weight loss, tiredness, hypotension, hyperkalemia, and so on. Another group, patients who are taking steroids and you are planning to withdraw the steroids, because we need to know, are they having adrenal insufficiency? Is it okay to stop or no? Also in patients, preoperative evaluation who are taking or history of taking steroids, they need to be evaluated too. So how we diagnose? 2 steps: confirm, and then we localize the disease. Confirm the test is by doing serum cortisol test, either basal or synactine stimulated test. And in here, you have to make sure which assay in your hospital or the lab you are using is using. Because the older assay, they use polyclonal antibodies and their levels are high. The newer assays, monoclonal antibodies or mass spectrometry, are more accurate and they are using lower levels. Like in our hospital, they are using monoclonal antibodies, and this is more specific and more accurate than the other one. So in patients suspect adrenal crisis, we don't wait for result. We just treat, and when we put the IV line, we draw blood for cortisol. If the blood level comes below 18, this is adrenal insufficiency. If it comes over 18 milligram per deciliter, then this patient does not have adrenal insufficiency. In patients who have chronic adrenal insufficiency suspicion, then we measure AM cortisol. If the patient have typical symptoms and the blood level below 3 microgram, then we say this patient have adrenal insufficiency. If the blood level comes over 18, then we say for sure this patient does not have adrenal insufficiency. The problem we get all the time, the blood level is between 3 and 18. We have to see then which assay we are using. If you are using the old assay, then your 18 is the cut point. If you are using the newer ones, your cut point is 14. In this case, we perform ACTH stimulation test. And how we do that? Simple. We ask the patient to come in the morning, preferably fasting. We draw random basal cortisol level. We give the patient synactine 250 microgram IM or IV, and then we measure cortisol level at 30 minutes and 60 minutes. And then we look at the numbers we get. We look at the absolute number, because 10 years ago we used to say increase 10 points from the baseline is also okay. Not anymore. We look at the threshold. It has to be above 18 to say this is normal. So if the patient level below 14, then we say this patient have adrenal insufficiency. If the patient level over 18, then we say this patient most likely does not have adrenal insufficiency. And the problem is when you have the level in between. In this case, we have to know which assay we are using, and if we don't know the assay, we have to use DHEA. The reason for that, because DHEA also is getting low in adrenal insufficiency. So if we do it, and the blood level comes back normal for age, then it makes adrenal insufficiency unlikely. So give you some scenario for the synactine test. This patient has a baseline of a 22, after half an hour 14, and then after 60 minutes 25. As you can see, the numbers here above 18. So this is normal response. This patient has the baseline is 5, but the 1 hour is normal. So this could be either they are taking steroids, so that's why the morning is low, or they have recent injury and in the pituitary gland, which have acute loss of ACTH. So you have to go back to the history and go what's going on. The third one here, patients have low baseline and the stimulated also was low. So this patient have adrenal insufficiency. To tell if it's primary or secondary, we do ACTH. If it is low, then this is secondary. If it is high, this is primary. So again, as I mentioned, DHES, look if it is normal, make it unlikely. What about patients who have abnormal CBG? because sometimes we find this situation. In this case, we need to measure the free cortisol level. And the best one is the salivary cortisol level. And again, the values, it depends which assay you are using. We can use the basal, using, for example, here, the spectrometry or immune assay here, and they have different values. So we need to know the basal values for these assays when we use cortisol level. It's very important. This is just summarize the approach. Cortisol level, below 3, diagnosed, over 18 ruled out, in between we do Senectine test, below 14 adrenal insufficiency, above 18 rule it out, in between, in this case we do patient DHES, if it is high, adrenal insufficiency unlikely, if it is normal, if it is low, likely, and so on. Now second, we diagnose the patient now, we have low cortisol level. So what's next step now is to localize the disease. In this case, just to give you a quick summary, we do ACTH. If the ACTH comes back high, then this is primary adrenal insufficiency. If it comes back low, or in the lower range of normal, then this is secondary. The issue now when it comes in the upper half of normal, is it primary or secondary? Then next step, what we do, we measure aldosterone. If aldosterone is low, then this is primary. If aldosterone is not low, is normal, then this is secondary adrenal insufficiency. And just quick about primary, the most common cause is autoimmune. So history is important because medications, other conditions can affect adrenal gland. So we need to rule out malignancy, infiltrative disorder, anticoagulation. For example, someone in the ICU on heparin and all of a sudden become hypotensive, think about adrenal insufficiency. And the metastasis, look for neurological signs for renal dystrophy. So the next step, once we diagnose the primary adrenal insufficiency, is to measure 21-hydroxylase. So the first step, AM cortisol or Senectine test to confirm adrenal insufficiency. Next step, ACTH level to localize the disease. If the ACTH is high, then it is primary. After that, we look for the cause for the primary. We measure 21-hydroxylase deficiency. If the antibodies are positive, then this is autoimmune adrenal insufficiency. If it is negative and male, then we order a very long chain free fatty acid looking for ALD. And if it is normal or negative, then we go for adrenal CT scan. In females with negative antibody, we go for CT scan. And then according there, we go from there. If the patient have multiple autoimmune disorder, then this is polyglandular autoimmune disease. If the patient CT scan is normal, then we say idiopathic adrenal insufficiency. So treatment, cortisol in all patients, whether primary or secondary, mineralocorticoid, fluoronate only in primary adrenal insufficiency, androgens, DHEA, usually we give it in females. If they have problem with female sexual dysfunction, complaining, we start them 25 milligram for a few weeks, a couple of months. If no response, we can go up to 50 milligram. And then we have to make sure about replacement during stress or surgery. Sick day rules and patient education is very, very important. And treatment of adrenal crisis also is very important. When we give steroids, we need to give the lowest possible dose, preferably hydrocortisone. Typically, we give it 2 to 3 times daily, between 15 to 25 milligram. For example, 10 milligram in the morning, 5 at noon, and then maybe another 5 milligram at 4 p.m. And don't give it too late because the patient can get insomnia. And usually how we follow them, clinical assessment rather than laboratory. For insufficiency, we look for fatigueness, tiredness, and weakness. And then for excess or use, we look for hypertension, edema, obesity. And then don't forget bone issues here in patient who taking steroid, DEXA scan if indicated. And then sometimes we measure ACTH. If ACTH comes back low, then it means we are over-replacing them and we have to cut down the dose. Mineralocorticoid is given once daily between 0.05 to 1.1 milligram, and we follow up them with renin and electrolytes. We need to make sure renin here toward the normal side. And then what about patients who are going for surgery? This is very important because when you give someone a steroid, they may not have fever. So keep an eye on infection, don't follow the fever. Look at the patient history and examination. And patient response to steroid varies. Some people may not have suppression of the HPA axis, some people may have. So it's very important to approach this patient individually and see which one need further evaluation, which one need extra doses, and which one who do not. Remember this, 5 milligram prednisone, more than 3 weeks. That's a number to remember. Any patient who takes 5 milligram prednisone or equivalent more than 3 weeks may have HB axis suppression and need to be evaluated. We do group these patients to 3 parts. One, who have normal HB axis, people who have suppressed HB axis, patients who we are not sure on the intermediate. So who have the normal axis? Any patient who take less than 3 weeks duration of any kind of steroid at any dose, or taking 5 milligram at any time for any duration, or 10 milligram every other day for any duration. These patients, we can assume they have normal HB axis and no need for further evaluation and no need to anything and no need for extra dose during surgery. What about who are suppressed? Any patient take more than 20 milligram prednisone more than 3 weeks, or they look cochinode in examination. These patients, we can assume their HB axis suppressed and they need extra supplement doses during surgery or any stressful situation. What about the intermediate group who are taking steroids between 5 to 20 milligram prednisone more than 3 weeks? We are not sure if they have suppressed or no. See, these patients, they need further evaluation. Typically, we do ACTS or AM cortisol and so on. What about patients who use steroids for the last year? Because we know HB axis can be suppressed even after you stop steroids for up to 1 year. So any patient in the last 12 months who've been taking steroids more than 5 milligram, more than 3 weeks, need to be evaluated for HB axis suppression if they are going for any procedure. What about inhaled steroids? Same thing. If they're taking high dose inhaled steroids, like 75 microgram of fluticasone, they may have suppression and they may need evaluation. Even topical steroid, more than 2 grams of high potency steroids, more than 3 months, need evaluation. Any patient who look hyper or hypoadrenal on examination need evaluation. Same thing with injectable steroids. If they receive more than 3 injections in 3 months prior to the procedure, they need evaluation. So how we evaluate these patients? We do AM cortisol. If it is below 5, then we say they have suppressed axis and they need additional steroids. If their level more than 10, we can assume this HB axis is okay and then they can continue their normal steroid dose. If they have between 5 and 10, in this case, we recommend to do synactine test. And if the blood level more than 18, we can assume the HB axis is normal. Less than 18, we can assume they're having issues and they need extra doses of steroid during the surgery. Remember, if the surgery is urgent, don't wait for ACTS. Just assume the patient have adrenal insufficiency and treat them accordingly. What about adrenal crisis? Is the life-threatening emergency. If you suspect, you treat. You don't do evaluation and you treat. If you suspect, put an IV line, draw the blood, and start treating the patient with the fluids and cortisone. These are the symptoms in adrenal crisis. Typically, the patient comes to you with hypotension and shock. If you go and ask them, they may have these symptoms before. And this is the treatment, fluid, up to 6 liters they may need over the next 2 days, and steroids, bolus 100 milligram, and then 50 every 6 hours, or continuous infusion of 10 milligram. And then after restabilization, you need to look for the cause of adrenal crisis. Remember, education, education, education. Almost every other patient who comes to our clinic have no education about sick day rule, at least that's what they say. And they don't carry this with them. Patients need to carry with this because if they collapse somewhere and emergency call, they look for this. If they have it, they give them steroids right away. So this is very important. I have the patient here, they ordered actually from the US, and now they can do it at the jewelry store with adrenal insufficiency here. The sick day rule, a quick way of doing it, 3 by 3. Triple the dose for 3 days. That's a quick way of doing it. Or you can follow this. If the patient feeling unwell and taking prednisone less than 10 milligram, double the dose. Between 10 to 20, make it 20 milligram. Over 20, they are safe, continue. And if they're taking hydrocortisone, take it 20 now, and then 10 every 6 hours till they feel okay. But I think 3 by 3 is much easier to remember and then to explain to the patient. If they cannot take it orally, for example, severe vomiting or diarrhea, or going for a procedure, or major car accident, major trauma, major surgery, or preparation for colonoscopy, they have to take it in injectable form. Summary, you need a high level of suspicion of adrenal insufficiency because the symptoms are non-specific. Remember, tertiary is the most common because of medications. And if you suspect adrenal crisis, you treat, then you investigate. You don't investigate and wait. And start with AM cortisol. Dynamic test sometimes needed if your diagnosis not 100% with the AM cortisol. And then ACTH level can help you between primary and central. Remember, sick day rules to the patient and explain and educate the patient is very important. And stress doses during surgery or stress is very important. Thank you.